the price list that we're working with, they include like thousands of prices.
Right.
And healthcare is also a field that is constantly developing. Like, again, back to what are the new medical guidelines for this specific procedure? Like, okay, now we have seen that it's better to do it like this, or like, okay, now we need a code. Like, you know it from medical coding, right? I think actually the medical coding as the foundation for billing is very much like expressing the complexity of billing, because there are so many codes, and there are codes for everything. And if you then on top of having these thousands, if not hundreds of thousands of codes, also have rules about how we can combine them, then you can imagine how complex this workflow can actually become.
Simon, we're here to talk about medical billing. I just want to set the scene a little bit for everybody who's not familiar with this. At Corti, we are talking a lot about medical coding as a general topic, specifically because some of the research that's been done at Corti is focused on that at the moment. When we talk about medical coding, we always talk about it servicing sort of three domains. Maybe just to set up what it is to start with, it's essentially taking key elements of a consultation between a patient and a doctor, the diagnosis and procedures and so forth, and then taking that text and translating it into a set of alphanumeric codes. We've talked about this at length in other formats that I can share for anyone, but essentially that's the purpose. And the reason that we do that is that if they're alphanumeric codes, it's easier to transfer them through the various systems. So in electronic health records, for example, so different healthcare professionals know what went on in that consultation.
Yep.
That's probably reason number one of three. The second reason we do that is that it forms the basis of all of the statistics that we use in healthcare. So population health, epidemiology, statistics and research, all of that sort of stuff. This is where we get the searchable and easily accessible overview of how prevalent certain diseases are and things like that. And then the third reason is billing. So we don't want to take a long form text of documents that a doctor or a nurse or somebody's written and say, okay, I wonder what that's worth. There is actually a system to this, and it starts with these medical codes. But at Apollon, you're solely focused on that third use case. Basically, how do you do a good job, as I understand it, from getting medical codes and then everything that needs to go on to turn them into billing codes and fund the system. So if I stop there, maybe you can just introduce us a little bit to what is medical billing.
Yeah. Medical billing is a highly complex, multivariable, and manual workflow for most healthcare providers in the world.
Fun.
Exactly. Because as it is, like, somebody needs to pay for healthcare at the end of the day in some way, shape, or form, right? And the payer pays by paying for a bill. So billing is basically figuring out exactly what needs to be on that bill in order for that bill to be compliant according to rules, and of course also what needs to be on that bill in order to charge as a provider for what you are allowed to charge for that bill to be compliant. And below that exercise or workflow is, as I said, it's multivariable, is a lot of different variables, factors that influence how that bill needs to look like. That comes in the form of a contract between the specific provider and the specific payer, whether it's either the system or private health insurance or the private person in general. There's typically also price list involved with a price for each of these codes, but then each of these codes can have different tariff types. They can have different forms depending on whether they're used in an outpatient or inpatient setup, whether they are used together with general anesthesia or with an implant as well. So there's also a lot of logic inside the actual price list. And again, you also have, as the same way as with the contracts, you have unique price lists for each payer, because a hospital or clinic typically have or can have specific agreements with the specific payers in order how much can you charge for this type of procedure or for this type of service. Then you also have guarantees of payments, authorizations, which is typically also an element in many markets in some way, shape, or form, that you need to get authorization in order to be able to perform the needed procedure. And they also have different elements involved and different rules attached to them. And then even on top of that, you also exactly have different types of conditional formats that needs to be in place in terms of how that bill needs to look like. So yeah, in essence, it's a massive operational and data infrastructure problem that sits behind or below every healthcare administration.
Can we set some even more basic facts just briefly, which is you use the word payer.
Yeah.
Now, if you're not heavily in this system, like what does it mean? What's a payer in a healthcare system? I sit here in Denmark where it's predominantly a public and seemingly free system.
Well, yeah. So start like a payer is typically either the public system. We can get back to that because also in Germany, for example, it's still a public system, but it's basically structured as multiple insurance companies that you have a like statutory health insurance. So you need to pay to it, but it's still like actual insurance companies. Then you have the actual private health insurance companies that you also have a lot of in Denmark, for example. Like in Denmark, 2.9 million people, almost all full-time employed people in Denmark have a private health insurance. So it's actually, Denmark is actually, despite actually being perceived as a free public healthcare system, private healthcare indeed covers a lot of the demand for healthcare in Denmark. And then of course you also have private payers, or like that people as a private person needs to pay for healthcare. So I think that is the three main categories of payers. And then maybe also, I also tend to use the word provider, which is also this general term for basically a healthcare provider. So it can either be a private hospital, it can be a public hospital, it can be a clinic, or it can be like a general practitioner, like a doctor's office. People that provide healthcare, companies, institutions that provide healthcare.
Is there much similarity when it comes to billing? And so that we get into the technical side in a minute, but is there much similarity between the complete private sector and the other extreme being sort of these private or insurance companies? So not maybe like leaving examples like Germany out for a little bit, just here in Denmark. If I go to my my local GP because I've got a itchy nose or something, I'm not that bad, but and you know what is the workflow, if you will, look like from there to that GP getting paid, or my visit at least being paid for?
Well, again, here there's actually also for general practitioner, like of course the private person never see the bill in that case, or very rarely do. They have some self-pay services, but in general, they also exactly write down a journal. That journal is basically coded, and then there are as I recall, 30-50 page contract, or you can say guidelines of how these different codes can be combined and what certain codes do not allow for and what other codes allowed for in terms of combinations. And this is what the doctor then basically, based on that journal, they pick the codes, and then they also need to pick what can be added to the actual bill and then send off to the payer. And the whole point of also, because coming back to the healthcare system as such, right? Like healthcare in general, I think is one of the, apart from LLMs these days and tokens, which there's an endless demand for. So of course, and it's a very expensive service in general. So in order for the system to work, there needs to be some control mechanisms in terms of how and what type of healthcare you can access. And that is basically the way that the payer, whether it's the public system or private health insurance, is controlling for this, is to set up different rules for what you can charge for. Because that, at the end of the day, creates an incentive or creates the alignment in terms of what can the providers actually perform. And that is, again, back to the whole point of billing, that is that the payers do a lot of controlling themselves. So they, every time they receive a bill, typically controls it for whether is this according to the rules that we have, and if not, they send it back to the provider that then needs to edit it. And that is why it is even more important, or as important, for the providers to really get this billing right, because otherwise they basically get it back, and either they have to reduce the bill or they are not able to charge for it.
I promise we'll move on, but I really want to I actually don't know how this works. So these clinics, like the GPs, for example, and it'd be interesting to know if it's different in the hospitals. They're funded by the public system, but if I understand you correctly, you're saying it's still essentially an exchange between, even though it's a government fund, they are choosing to pay or not pay, and therefore that doctor's clinic will have more or less money at the end of the month depending on what they're given. It's not as simple as they're like government employees who get a salary and see patients, and they are ultimately essentially a small business, even though their main customer, so to speak, is the government.
Indeed. Fully correct, right? And especially general practitioners are exactly like individual companies themselves. They're then working under a license. Not sure what they have a ydernummer in Danish. Like, so you need to have that specific number in order to be able to practice as a general practitioner. And when you have that, there is specific rules about what you can charge for and how you can charge for it. And again, like also, the public system is basically just one large insurance, right? We pay over our tax for free healthcare. But again, as I said before, because you can say that healthcare, if it was just completely free for all, in Denmark, you of course also have different other kind of like control mechanisms, which is exactly you cannot access a special doctor typically without going through your GP. So they are basically the doorman of our system for good reason. Because again, then you would just have costs that would run off basically, right? So public healthcare is indeed also some sort of insurance, and that's why also that exactly also the private hospitals, like a large share of their patients are basically patients coming from the public healthcare system. At the end of the day, in Denmark, you have this rule about that if you have more than 30 days wait time for specific surgery, you're allowed to go to a private offer. And in that case, then it's actually the private hospital that will then charge the region where this person is living, basically. And that is the exact same thing. That is exactly a big part of what we do today, is actually help the private hospitals maneuver the many different rules and conditions that needs to be in order for them to charge for a procedure that they have done on a patient that actually came through the public system.
Yeah, it's really interesting because the complaint, you must have heard it as well from all of the expats, all of us whinging, whining expats, is that healthcare in Denmark is free, but people do often complain to me that they feel like it's a bit bare bones.
Yeah,
you know, like usually the suggested treatment is maybe paracetamol and wait a week. I'm exaggerating, of course.
No.
But of course it's a feature and not a bug. It's deliberate to make sure that there is a control over care, and that we make sure that people who go to the doctor with an itchy nose don't get too much treatment and whatnot.
Exactly.
So,
and to make sure that it's free, right? Because if you didn't have those control mechanisms, it would be difficult to keep it as a free system, complete free system, right? Also, even in Norway, you still have, like, I think you have a self-pay of like 200-300 kroner, I think it is, in order to go to the GP, just to create that kind of like personal disincentive for not just using your GP as a person to speak to, right? But in Denmark, we still have this system, and you can have many opinions about that. But of course, then that requires other control mechanisms in order to keep it like this, right? And I think it's also just, you can have many interesting conversations about this, but of course, it is very much a matter of, because the US systems, of course, have many shortcomings in terms of healthcare. But of course, it's also true that in US, you can almost get access to anything you want if you want, right? And if you're able to get to pay for it, basically, right? But of course, in Denmark, it's also true, like just certain types of procedures, certain type of medications that you cannot get access to. And that is, of course, like the other side of the coin, if you want to put it like that.
Yeah, I think it's the way you're setting up is like it's really interesting, because if you think about sort of the funding mechanism, I know that you have I think an education in finance, right? So I'm going to really make a fool of myself now, but the sort of lubrication for trade that money is supposed to be of a system that we've set up to function a certain way. It's a different mentality to thinking about it as like companies trying to basically profit off of the
exactly
giving patients care.
And I think that's a very good way of expressing it, where you would be able to argue that in US it has tilted over to the point where it's actually companies trying to optimize for profits, basically, right? And of course, like private hospitals in Europe are also companies, right? But of course, you also still have a contract-based, rule-based incentive schemes in order for them to actually treat as you would like them to treat it. to treat a specific patient. But you're right, like it is, no matter how you would look at this, like a bill is basically a way for a system to function, basically, right? Like you create this element that needs to be according to certain rules in order for you to instill the right incentives into actually how you provide care.
Yeah. I think whenever I've spoken to friends and family, or just sort of like the general public about, I've been talking to people a lot about medical coding recently, and whenever I get to the billing piece, it's sometimes spoken about almost like, but let's be honest, the real reason is the billing piece and stuff, as though that is in some way kind of different to the rest of the incentives in the healthcare system. And I think the way you describe it just reminds us that it's not. It's a necessary part of it.
Indeed.
Even if you completely wanted to strip any sort of profiteering out of the system, which for good reasons you probably don't want to, but even if you did want to, you would have a billing system still. You would still have invoicing.
Exactly.
And you would have.
But I think actually, the best example or best case to explain that is actually like internally in the Danish public healthcare system, between the 5 different regions that we have today. If a patient gets treated in another region where it lives, that region sends a bill for the region where it lives. So there's also interregional billing going on in the Danish public healthcare system, because it's just a way for, like, also public hospitals are running on budgets. Like, somebody needs to have a salary at the end of the day, and that is basically why this trickles down to, okay, how do we actually set a budget, and how does that then make us able to perform the necessary procedures, right? So things are still running based on, well, I won't call it money, but like a way to actually
trade.
I
think we've done a pretty good job, no doubt still quite complicated, but explaining why just trying to get this complex trade to happen that is necessary in any kind of sophisticated healthcare system requires the act of billing and essentially financing. We've talked a bit about that complexity, but why is it a type of complexity that lends itself to novel technologies, specifically artificial intelligence?
So again, you have these contracts which are basically 30, 40, 50, sometimes up to 100 pages of written text that are basically rules written in natural language, right? That are part of the basis for how you can bill. And then, of course, you have other elements, as I mentioned before, that are also written in numbers or written in text, right? And that is just a very, because it influences and because you have so many variations of how a certain procedure can be charged for, what other code sits in context of that, what is the diagnosis of the patient, what type of treatment was given in full, what is the length of stay if this was an inpatient, and multiple other elements, right? It is just very, very complex, and it is something that is almost not suitable for the human brain, right? I'm sometimes saying that, well, like these contracts are written by humans, but not for humans, right? And also these contracts are, because it's so complex to probably like actually express clearly, it is, and I've read many of these contracts, it is very difficult to actually understand what is this rule actually saying, and how am I going to interpret that into the real world. And on top of that, you have a lot of rules that are not written down. Like for sure, like the rules in our engine, 40% of that I would probably say is rules that are not written down.
Can you give me an example?
So, for example, in Denmark, the rules that sits around guarantees of payments, like what type of guarantee for payment allows for what type of procedures, when is a certain guarantee of payment needed, and when does a guarantee of payment qualify for you to charge for it, and when does it actually not qualify to charge for it. I'm still trying to keep it fairly overall, right? Those rules are not written down. That's something that sits inside medical biller's head, or something that you can basically talk to the payer about to understand, like, what does it actually mean when that specific guarantee of payment is expressed like this in terms of how I can bill. On top of that, you have these contracts, but then you have like continuous updates to it. Like it's also a good example of like the payers even publish FAQs, because it is, again, there's so many questions about what if we do like this and this and this instead, right? So many of these things are both complex as a starting point, but also very gray zone areas in terms of how actually to interpret this.
I assume that's just because if you made it too explicit, then you just make it too rigid and...
Yeah, probably, maybe, or it's just also like, it's just sometimes very complex to actually communicate, because there are so many different scenarios that you can imagine, right? Also, the price list that we're working with, like, they include like thousands of prices.
Right.
And healthcare is also a field that is constantly developing. Like, again, back to what are the new medical guidelines for this specific procedure? Like, okay, now we have seen that it's better to do it like this, or like, okay, now we need a code. Like, you know it from medical coding, right? I think actually the medical coding as the foundation for billing is very much like expressing the complexity of billing, because there are so many codes, and there are codes for everything. And if you then on top of having these thousands, if not hundreds of thousands of codes, also have rules about how we can combine them, then you can imagine how complex this workflow can actually become. And just another like anecdote, like I think in the beginning of us starting to really understand this problem, we interviewed a medical biller in a large private hospital, and as she said, like, Simon, like 5 years ago, our contracts were probably 5 pages. Today, they're 50 pages. So you're also just seeing this increase in complexity. Again, back to that it's a developing field, it is endless demand, and you have payers that are more and more aware of basically how to do cost controlling.
Yeah, so we generally see that in healthcare, the sophistication of it is growing year on year. The amount of specialists that we have, the amount of surgeries that exist, the amount of drug interventions that exist, the type of data that we can use to monitor the condition of the patient over time. All of that is adding accuracy, I would say, to the picture, of course, but also complexity. So we get this kind of fragmented healthcare system, and medical coding and billing are part of the attempt to kind of glue all of this together. Yeah. And if you're gluing an increasingly sophisticated, complex, fragmented thing, it becomes tenuous. Yeah.
Exactly.
Okay.
Yeah.
So made by humans, but not for humans. Makes a lot of sense. Yeah.
Exactly.
Nice.
So exactly, like another way of expressing this is that medical billing is actually a machine learning problem disguised as a financial workflow. And that is why also that we see that machine learning is just very, very good at, first of all, based on natural text, to actually extract patterns or rules, and that is why we are exactly using AI and machine learning for developing an intelligent engine that understand all the complexity and the different ways in which the different formats, or as I like to say, influencers, can have an impact on a compliant bill.
So if you're saying that this complexity isn't really appropriate to people, as somebody who's like not good at even remembering grammar and things,
exactly.
I concur. How do you prove? You said that language models, perhaps, and machine learning in general is good at this. How do you prove that? What are the experiments that you've run to test out whether or not this is the right technology?
So in the early days, like, first of all, are you able to basically hand over a payer contract to a LLM, to a large language model, and is it able to exactly extract rules from that from that contract in a meaningful way, and in a way that includes enough, like, that is rich enough in terms of understanding the different edge cases that are related to that rule. And in the early days, not so much. So also when we actually created our first rule engine, we basically read the contract ourselves, highlighted it in multiple ways, had numerous conversations with experts in this field in order to basically understand these rules ourselves and then write them manually in code. But that, of course, have then allowed us to now have a system that understands the relationships or how rules are expressed, and hence is now capable of exactly taking a contract, and then, of course, also adding, which is the other element that we do, basically extracting rules and comparing those rules to the patterns that the AI is able to detect in historical invoices, because historical invoices, again, we of course only take the ones that have been finally approved by the payer. They include basically rules, right? You can extract rules for how combinations of codes sit in a bill, in an approved bill. So when you take rules from a contract and you compare those to rules that are being that are sitting in approved invoices, you're able to create a pretty good foundation for how, okay, the rules for this specialty area for this payer looks like this.
So if I understand you correctly, you're saying that the nature of billing, like the fact that you have access to contracts and then you have access to approved or not approved, that in terms of the training data for these language models, it can be quite pure.
Exactly.
Yeah.
And then of course, then you get to an area around like I would say 90-95% in terms of that. When you then take those rules that you have pulled from the contract and you put them, or you take the historical invoices through that rule engine, you typically see that 90-95% of the prices are set in the same way. Like the engine sets the prices the same way as it was built. Then there's remaining, let's say 5%, and that is either because the engine needs some fine tuning, because there are some edge cases that still need to be, so to speak, fine tuned, or it's because there's actually been some mistakes in the past about either overbilling or underbilling. And that is typically how we start an engagement with a hospital or with a provider, is actually let's start by looking at your historical revenue, and let's try to see what patterns we can see in that in terms of the compliance of your billing.
I'm interested to ask you about the workflow here, because from what I know about training these models, and actually I know this, I don't know, coincidentally from medical coding, that one of the challenges is that if you have new codes added to the to, for example, ICD-10, you know, that like COVID comes along and all of a sudden that's a new code that the system hasn't any training data on, but it's actually not a rare code. It's quite prevalent in the community. And then you add rare diseases into that as well. That basically the story that I've been told is that I think you're calling them like these edge cases, right? But they're new edge cases introduced regularly. Yeah. And then, as you said earlier, we have medical codes as tens of thousands of codes. Yeah. And as you said, it's not even just about those codes. It's about the endless combinations of those codes, some of which are approved and not approved. Yeah. So just from that training data point of view, how do you handle that?
Yeah. Of course, there will always be edge cases on new additions, new edits to the rules, right? And in that way, we have two ways of ensuring that our engine constantly improves. It can either self-improve by basically, so every time if working with us, every time you send out a bill and you get a signal back from the payer, like we do not approve this bill, that is basically a rule. So like actually also a third way to see rules, like one thing is what's sitting in the contract, another thing is what's sitting in the historical invoices. A third element is actually the denials that you have received over the past, let's say 12 months, right? Because denials is also, how does this specific payer interpret these rules? Which is basically a rule because the payer, unless of course you can dispute it and you can win that case, is basically interpreting rules, and that is then the rule, right? So our system will then be able to exactly self-improve, like, okay, there's a signal now that we cannot charge like this. Let's adjust the rule for this specific provider in this specific relationship with this specific payer, that you can no longer charge like this. And that is again where AI come into our field and how we are taking advantage of it. Because of course, as I said in the beginning, we hard-coded manually the rules for a specific contract. That would, of course, not scale because these rules, like there are multiple contracts and these rules change all the time. So what our system is capable of doing today is both to self-improve based on this signal, but also that we or the medical biller, the secretary that understands these rules or understands like, okay, now I've been informed by the payer over a mail that now they want us to bill like this. I need to change this rule. And this person can then write in actual text how this rule is now working out. And through basically, again, what AI is very good at, which is turning natural text into code. It basically now create a new coded rule according to this change or edit of a rule.
Do you think that's the sort of long term for this? So again, in the coding of the like the disease and the treatment and so forth, like the medical coding piece, there's so little, essentially no tolerance for mistakes. So the way that I understand that most systems, not talking about Corti specifically, so like just most computer assisted medical coding systems handle that, is that the AI suggests a handful of codes, and there's always a human being there saying, yep, oh, you forgot one and whatnot, right? So what's interesting, I think, from the billing point of view is, maybe you'll tell me I'm wrong, but I think from the billing point of view is that if a bill gets sent and then denied and needs to come back, that's not as detrimental as a patient's record lacking a particular comorbidity, for example, that then goes on throughout the healthcare system and they're treated accordingly. So I just, after that massive preamble, your opinion on like where this ends up, is it that you sort of, because the system can self-teach based on denials, you almost allow for that teaching mechanism to be part of it? Or do you think that there's always got to be a human being doing a review to just to minimize the number of denials before they even come back?
So I think for a certain part, and I think what we are aiming at is basically to give the secretaries and medical billers superpowers, right? Like the people sitting and doing the job today. I don't think it's possible to kind of like in any way substitute these people, because this is, again, constantly evolving. It takes a human brain sometimes also to actually see the context of what is this edge case meaning, basically, right?
We are good at some things.
Exactly, we are good at something, no, for sure. But I think what we can do is that we can exactly allow them to focus on the less repetitive work, because indeed within medical billing there are a lot of invoices which are less complex, not because they're not complex, but they are less complex than the complex ones. And that still requires today like 3, 4, 5, 6, 7 clicks in order to actually send off, right? And hence takes up a certain amount of time. But you can basically, again, if you have an engine that is intelligent enough and understands the different variables, you would be able to exactly automate a large share of the total volume of bills being sent, and hence allow the people to actually focus more on the more complex ones that are needing more human attention, right? So that is for some part of it. And the other part is, of course, even though that a human needs to be involved, there's still a lot of the work that can be improved by basically delivering the relevant information for the specific context. So now you're looking at a specific invoice for this specific patient with this specific, within this specific specialty, within this specific payer. This is what you need to know. Like also, I think another good way of explaining this is actually like what we experience is that many of the billing teams or secretary teams that we are helping today, they have already internal notes, like that are sitting in OneNotes or Excel sheets or something like that, that tries to kind of like keep all these different elements somewhat structured, right? But again, that is something you need to go and look at, and then you need to go back, and then you can go look at it, blah. This can, of course, be elevated, or this can be like showcased when you're sitting specifically with this invoice in terms of how you need to remember that this specific payer want this bill to look like. But in general, like I think the large vision for what I'm seeing is that because this field is so complex, and I don't see any signs of this complexity going away, on the contrary, and because that this is very much, I think, this is also what I think I have learned over the many years of working with different types of admin problems in relating to businesses, and also financial admin problems, is that this is actually in many cases what creates the inefficiency in a sector and in an industry, right? So the issues of, or the complexity of billing is I think to a large extent limiting the capabilities of our healthcare systems. So what I'm seeing in the future is that you can create this standard that holds rules in code and have a complete understanding of all the different variables and are able to self-improve and easily update, and is also auditable. So you can basically trace every, so to speak, decision down to where this stems from. You're never in doubt. There's never like a discussion about how should this rule be interpreted. So if you can create this, what we call the clearinghouse for European healthcare or for healthcare in general, you will be able to exactly create a much more frictionless, smooth way of providers and payers to work together for the benefit of everyone, basically, right?
We've talked about the fact that billing, medical billing is inherently complicated, and then it's also immensely different depending on, or it sounds at least, it's very different in depending on which country you're in, which context you're in. Are you considering the entire healthcare system or strictly the private or strictly the public? So just talking about Apollon now, and maybe you can also detail a little bit more about the technology. What's your go-to-market strategy? What's your approach? Which of these problems are you going to attack first, and why?
Yeah, so I think first of all, and I think that is one of the insights that we have built out over the past years working in this topic, is that yes, there is indeed, of course, differences in terms of how the different healthcare systems work in Europe. But again, as a fundamental element, you still do perform certain procedures as a provider. You write them into a journal, you code them, you then basically put those codes into a type of bill that you then send off to the payer. And in order to put those relevant codes in the correct way into a bill, there's an element of logic here, right? Like I would say that another way of expressing this is that no matter in which market, in which country you're in, and looking at an organization of a healthcare company, of a healthcare provider, public or private, you have secretaries or medical billers that actually perform the job of creating a bill. So that tells me that there's a fundamental underlying element which goes across all type of markets here, right? And you, in order for these to do their job correctly, they have to know of contracts, know of price lists, know of guarantees of payments, know of all kinds of different conditions that this bill needs to comply with. And that is basically how we're seeing that we can exactly build this engine that is able to encode all these rules across these different markets and continuously learn. So there's a huge element of data networks effect here, right? The more bills we basically process, the smarter our system becomes. Again, back to the vision of building this European clearinghouse for healthcare. And of course, we have to start somewhere. So we have started in Denmark and are working with various private hospitals on exactly starting by giving them a sense of how does their what is the patterns of the historical billing, right? What is the potential for automation? What is the level of overbilling? What is the level of underbilling? There's another element which is the whole kind of like more like financial elements of cash flow. Like, are you actually billing according to the optimal time to invoice? Like, from you have finished that procedure, how fast are you at sending out the bill? Because often medical bills are quite large. So again, if you wait too long to actually send this bill, you have an impact to your cash flow. This is also something we can basically optimize for. And that has given us a very good understanding, again, of the fundamental elements of medical billing and trained our system, built our system of exactly being able to turn text-based rules into code, develop our system to understand all the different other elements that, again, goes across different markets, a price list, for example, or a guarantees of payment in other areas. And what we're now aiming for is exactly to move into one of the other larger European markets, most likely starting with Germany, as it is a very large market in itself. It is, again, very complex. You have the concept of the medicinske dienst. You have the the complexity of denials and how that impact a hospital's ability to exactly bill according to rules, and how much burden is put on them to actually manage all these denials. So that is the vision for us going forward. And of course, I see also two elements here. One, our system can actually be used like by the actual providers in their systems, but of course they're using an existing system to do the billing, right? So in that way, we integrate with that system also in order to not to change workflows unnecessarily, right? And what we want to be the best at is basically building this billing intelligence, and that billing intelligence can be ingested in whatever system you're working in to give you signals on whether you are about to send a bill that is non-compliant, basically. And hence, that intelligence can also very well work in the context of the systems that are already handling different administrative workflows inside hospitals, like the likes of KISs, or HISs, or ERPs, and so on, right? So what we basically want to become, again, the best at is to build the system that is able to handle all this complexity and multivariable impacts of medical billing.
Do you imagine it, and maybe you can answer also what it is now, but long term, do you imagine it as like software, as an application, or as an API endpoint, or how do you, because this integration and interoperability piece is tough in healthcare?
Indeed. Yeah, it's a good question, and I think because this is a very manual workflow, we see it as an application first and foremost, that it can exactly assist the people doing the job today and deliver the value for the hospitals in terms of exactly removing revenue leakage, which is a big part of the value that we deliver. Like, again, if a hospital, let's say, underbill themselves like 1% of their revenue, that becomes quite a lot of money, and that is actually like bottom line money, because it is services that has already been performed and they simply just didn't collect the money for it. So removing that is something that clearly benefits the hospitals. Obviously, also overbilling, removing that removes a lot of inefficiency, a lot of time spent on, again, you can say, valuable work. Instead of having to send an invoice once, they have to send it twice, and removing that is, of course, also a clear benefit. So yeah, first and foremost that, but of course, we also see the relevance of exactly working together with the different systems out there that already have a existing market. And as we see it, the area that we are in requires so much focus. So us being specialized in handling complexity of medical billing, I think, is a clear value for also these type of players, because it is something that is very difficult to handle yourself.
Yeah, I think it was before we hit record, but I asked you why, I don't understand, Simon, why are you only focusing on billing and why not the sort of epidemiology piece or something else? And now I feel like a bit of an idiot for asking that. It is complicated.
It is insanely complicated, and there's like so many people working on this on a daily basis, and it impacts so many elements of our healthcare system. And I think that is also, I think I'm not a healthcare educated person, but I was like, I think many years ago, I was like, okay, I understand software somewhat. I understand how you build businesses using software to solve problems for people. How can I use that in the most impactful way in regards to healthcare? And I think what I've seen is simply just that helping providers, helping in general the healthcare system to become more efficient in regards to billing is one of the most impactful ways you can use software.
Couldn't agree more. Simon, sometimes these conversations can feel a little bit almost indulgent, where I'm just talking to someone who's doing something interesting. But in terms of an actual call to action to this healthcare system out there, who can benefit from Apollon today, and how do they do that?
Yeah, so I think what we've seen is that as a fundamental element sitting across billing is basically, again, these rules, right? So that is what our rule engine basically is very good at figuring out when a certain rule is relevant for a certain claim. And that basically then allows, because these rules are sitting in code, that is what allows us then to basically use agents on top of that to help, to assist, to automate specific type of workflows for a provider. So that can, for example, be that you want to send a bill. It is still at a draft stage, so it basically just have the standard list prices on it, for example. And you want to make sure that those list prices are corrected according to the rules. And what our billing copilot basically does is that it set the suggested prices by understanding all the different influences that impacts this bill, and then set the prices. And a human can then review it. It, of course, also explains why it has potentially changed some of the prices. If there's some elements that are left out, for example, this code actually allows you for also charging for general anesthesia, or allows you for charging for implants. Have you remembered that? And then basically can accept this one. And then that basically gets sent off the correction of the actual claim and send out the claim. So that is one element of how we make use of this billing engine in the real world. Another element is, for example, like, again, the less complex bills that are there. Like, okay, we have now identified that there are these steps that this type of bill always needs to go through, and we can basically then create an automation that checks for these things, and if all those checks comes through, then you can basically send it without any human looking at it. So that's another way that we use this in order for giving more time to the secretary, to the biller, and at the end of the day, in regards to also the automation, of course, also speeding up the actual creation of a bill, what impacts the cash flow for these hospitals. And then there's, of course, the elements of that, as we talked about before, that in certain markets, denials is a pretty big part of the complexity, or handling denials is a pretty big part of the complexity. So in that way, our system, again, based on its understanding of the rules that dictates how a compliant invoice needs to look like, we can basically ignite, or we can basically activate our engine on a bill that is about to be sent and provide a denial risk score. So based on historical evidence, specifically for this payer and your relationship with them, what can we see that is typically being denied? So we can see, okay, here there's a missing clinical documentation, here there is a mismatch between the diagnosis code and the ops codes, or whatever it might be. And based on exactly historical evidence and the rules that are there, we determined that there's probably a pretty high denial risk. So you should change that, or you should adapt that, or you should request this specific documentation in order for this to go through. And then, of course, also in the case that you actually send off an invoice that then get back with a denial on it, how do you then handle that? Because again, in certain cases, it's also just humans on the other side, actually, right? On the payer side, they also do use systems or robots more and more now, which is also a bit of the reason for why we exist. But if a payer then sends back a denial, you still have to handle that in some way, shape, or form. And in that way, our denial agent is also able to basically better assist you on saying, well, this is a fair argumentation from the payer. You are missing X, Y, Z, or actually we have seen before that you have gotten this type of bill approved before, and you should as well. There's precedents for that you can actually charge like this. You should write like this to back. So actually having a denial management co-pilot that can help you figure out exactly how you deal with this specific denial.
Yeah, amazing. And what do you want people to do? You want me to give out your phone number in case anyone's interested in, or is there
No, indeed. Well, Apelon.co is where you get a better understanding what Apelon does, and of course that's also where my details are. And also just, are you interested in basically understanding what AI can do for medical billing? Like, it doesn't have to be more than that, right? We are well aware of that. This also requires a good understanding of the specific providers, you can say, setup and workflow. But that is, of course, also what we are just very good at. We have now seen a lot of different ways in which medical billing can be performed. We know how to apply AI to this in a sensible way, and can basically give you an idea about which of these processes could you improve by the power of this new technology, which is a good tool for many of these use cases.
Fantastic. Thanks, Simon.